So we will start and we'll go from there. So like I said, we're going to talk a little bit about normal fertility because that's really important to understand before talking about infertility. So normal fertility, you can see on the slides here, we have the female reproductive tract. You can see that we have the uterus, which is kind of obviously where the embryo will hopefully implant. You can see on each side, there's a fallopian tube coming out of the uterus. At the very end are kind of the fingers, or otherwise scientifically known as the fimbria, and kind of right near that fimbria are the ovaries, so one on each side. And with normal fertility, you have the ovaries, you have multiple little circles, which are called follicles, and in each one is a microscopic egg. And normally, if you have regular cycles, one of those follicles will get the signals from the brain to grow and then ovulate mid-cycle. And at that point, hopefully it gets caught by the fimbria of the fallopian tubes. And then at that point, it starts traveling through the tube. And hopefully there's some sperm there. And at that point, hopefully that egg and sperm will meet, become what's called an embryo. And then that embryo will continue the journey through the fallopian tube into the uterus, and then hopefully implant kind of in the upper third of the uterus to hopefully then go on and become a pregnancy. And so in terms of normal fertility, this chance of getting pregnant every month, typically we say it's about 20%, just because as I just described, there's a lot going on in terms of the egg and the sperm and the embryo. So even with everything going correctly, unfortunately, there is, unfortunately only about a 20% chance of it happening each month. And as we get older, that chance goes down. If we can time intercourse, meaning adding in something like an ovulation predictor kit, which tells you a little bit better as to when you ovulate, really with those, it's telling you when your luteinizing hormone is surging. And so by having intercourse on the day that that luteinizing hormone surges, which is when your ovulation predictor kit's positive, that day and the next day, you can increase your chance to about 30% each month. And so as you can see, it definitely takes many people at least a few months to get pregnant. And so over time, as you can see in the graph, kind of once we get to that 12-month mark, hopefully about 85% of couples that are trying are pregnant, but that still means that there's about 15% that are not. At that point, definitely, people will continue to try sometimes before seeking out treatment, and that number will increase kind of at the 2-year mark. But that being said, definitely the whole question as to what is the timing to then say that there's an infertility problem. And so infertility is really defined based on your age. And so if you're less than 35 years old, we would say that you should be trying over a year as long as everything looks good. So if you are someone that might have very irregular cycles, for example, you've been told you have polycystic ovary syndrome, if you know you have a major problem with one or both your fallopian tubes, or if you know that there's a major sperm issue, definitely, we don't want you to wait a year. You should come in earlier than that. But if everything, medical history-wise and GYN history-wise looks good, really just because of those chances, trying for up to a year definitely makes sense. And at that point, if you're not pregnant, come on in for a full workup and possible treatment. When you're over 35, because that impact of age definitely increases as we get older, we would want you to come in after 6 months, because the thought being is your pregnancy chances are just continuing to decline. So we don't want you kind of wasting more months at home when potentially we could be doing treatment. And then really the thought is if you're over 40, at that point, you might even want to come in right away just to get testing, make sure that we're not overlooking anything before you start trying. Other reasons besides infertility or being over 40 to see a doctor would just be if you're interested in testing and just seeing what your actual fertility is. And so what is this basic fertility evaluation that we're talking about? So for the female, definitely most importantly are the eggs. We want to know about the fallopian tubes. We want to know about the uterus. And then we definitely want to know about the sperm. So we're starting with the eggs. So this right here, you can see a beautiful picture of an egg. And so in terms of what do we want to know about eggs? So most importantly, we want to know kind of how many do you have? So we are born with all of the eggs that we're going to ever have. And unfortunately, every month, that number just continues to go down. And so ovarian reserve is a way of kind of telling us, do you have a normal number of eggs for your age? Is it a little bit high? Is it a little bit low? And so there's a few things that we look at to kind of tell you how is your ovarian reserve. So first is an ultrasound. It's done transvaginally, and we do that so that we can see the ovaries the best. And so with that, usually we try to do it in the early part of your cycle before any of the follicles have become that big follicle that's going to grow. And with that, we're really counting the little black circles on each side within the ovary to kind of tell us a number of eggs that look available for the month. That number over time does slowly go down, definitely from month to month. It's about the same, you know, and then just long term, it's just slowly going down. The other thing that we look at is a blood test called anti-Müllerian hormone, or AMH, and that is a hormone that comes from those follicles. So as we get older and that number of follicles goes down, so does this level of AMH. And so AMH, kind of most popular way of measuring it, kind of the assay that we use mostly for most places in the United States. In terms of numbers, this is for all ages. Anything over 2 is considered really good. Anything less than 1 is on the lower side. But again, this is all age dependent. So a 25-year-old with an AMH of 1.5 is considered very low, whereas a 41-year-old with an AMH of 1.5 is considered great for her age. So definitely important, if you're going to do testing like this, not with a fertility doctor, that they know how to interpret those numbers. And also things like your antral follicle count and anti-Müllerian hormone are definitely impacted if someone is or recently was on something like birth control, because the whole point of birth control is to what we call suppress, which means kind of quiet down the ovaries and keep you from ovulating. And so both of those can artificially look lower than they truly are if someone has currently or very recently been on birth control. So giving you some time for your body to get back to true baseline is very helpful. And then lastly, to really tell us how the brain and the ovaries are communicating, we check something usually on the 2nd or 3rd day of your cycle, which is called follicle stimulating hormone, along with an estradiol, or otherwise known as estrogen level. And that's just going to tell us how is your brain kind of talking to the ovary. Over time, that FSH slowly goes up. And once that FSH is very high, that makes it very hard to get pregnant. In terms of normals, anything less than 10 is considered normal for an FSH. Anything over 15 is considered definitely elevated. Over 20, typically we would, unfortunately, probably not be able to offer treatment because our medications wouldn't work with such a high FSH. But again, these are all reasons to get it tested and interpreted by a fertility doctor. And then kind of lastly, in terms of eggs, definitely if someone has regular cycles, we assume that you're ovulating. But if someone has very irregular cycles or really isn't sure, sometimes we will check a progesterone level, which is a hormone that goes up after you ovulate. And typically we would check that level for you about a week after you think you ovulated, just to make sure you're truly ovulating. Because if you are not ovulating, then there's really no chance of getting pregnant. And that's something that we can somewhat easily help you ovulate, typically with a pill. Whereas if you're having normal cycles and you're always ovulating, the concern is more about your egg quality. So kind of everything I've mentioned is about egg number, are you actually ovulating? Fortunately, there's no real kind of way to tell you what your quality is. Definitely age is what we use to counsel you. So as you get older, that quality is going down. We don't have a definitive way of measuring it. So in terms of ovarian factor treatment, once we get all of that results back, if you have poor ovarian reserve, meaning you have a low antral follicle count with a low AMH, or you have a high FSH, definitely, depending on those numbers and your age, we want to be aggressive because eggs, like we said, unfortunately, over time are just going down. So if someone has very low numbers of eggs and high FSH, definitely we want to do the most aggressive treatment, which is IVF. And we might even want to do a few cycles of IVF so we can do what's called banking, meaning doing extra cycles to get extra embryos in the freezer so that beyond getting pregnant right now, you actually have some extras that we can use in the future. And then, like we said, if it's more of a problem of anovulation, meaning you're just not ovulating, that's something that we could hopefully fix for you, either by doing a pill such as letrozole or Clomid to help you hopefully ovulate. Sometimes we might actually do injections if those pills don't work. And then with either of those, when the follicle with the egg is nice and big, we actually will help you ovulate with what's called a trigger shot. And so again, ovarian factor treatment kind of depends on what it is, what your age is, but definitely different kind of ways to treat that depending on what the issue is. We'll move on to fallopian tubes. So in terms of the fallopian tubes, as you know, those are what's going to connect kind of where the egg's coming out of the ovary to then get hopefully in connection with the sperm and then get to the uterus. So definitely we want to check and make sure those are actually open. So the test we do for that is a hysterosalpingogram, or HSG for short. We love acronyms around here. So this HSG, which is the top picture, is a normal HSG. And so with this HSG, you can see the triangle which is the uterus. And so basically the dye is going through the cervix up into the uterus and basically showing us that that uterus looks normal. Sometimes we see there's a huge area of black coming into that white, which is what we call a filling defect. And that could be from something like a fibroid or a polyp. And those are things we'll talk about in a little bit when we talk about the uterus. But really the most important thing for doing this HSG is to make sure the dye then comes out through the fallopian tubes and confirms that they're open. So this top picture, you see these little tiny thin areas. Those are the tubes. So the tubes are really small and thin. And we see these kind of billows of white at the ends, and that means that the dye has come through and they're coming out, so they're both open. Whereas if you compare it to the bottom picture, you can see the white dye has kind of gotten stuck, almost looks like a sausage. And so those are called hydrosalpinx. And that's when kind of fluid is always stuck in the fallopian tube. It means that that area is blocked, and so the egg is not getting through correctly. The sperm is not going to probably meet that egg. And so that's a major issue, and that would be a reason why someone might not be getting pregnant. If you just have it on one side, you still could get pregnant on the other side. Definitely, in this case, both sides are blocked. And so this is definitely something that would have to be fixed. And so fortunately, it's hard to really fix the tubes, but definitely you would definitely want that to be evaluated further. And so how does something like this happen? So causes of what we call tubal factor would be things like pelvic inflammatory disease, where you have something like chlamydia or gonorrhea. If you have a history of endometriosis, which is basically when the cells that are in your uterus that are supposed to be kind of causing your period each month start to grow outside of the lining of your uterus. And so it can cause problems near the fallopian tubes. It can grow in the ovary as what's called a chocolate cyst or endometrioma. But basically endometriosis can cause issues throughout the pelvis. So that would be something that could be looked into if someone was found to have an HSG like this. And then if you ever had any previous surgery, whether specifically in the pelvic area or something like an appendectomy, which is on the right side, kind of near that fallopian tube. So all things to look into when we look at your tubes. And so in terms of how do we treat this, really tubal surgery is difficult. For something like that last picture, unfortunately, the recommendation would be that a surgery definitely wouldn't be able to fix that. We might still do surgery to actually take the hydrosalpinx out, just because that can cause kind of this very toxic fluid to go into the uterus and decrease pregnancy rates. But really the major treatment would be in vitro fertilization, because with IVF, we actually are bypassing those tubes. But again, this would be something in your full workup that we get all the information and make a decision together as to what the best course of action would be. Now we're going to move on to the uterus. So I briefly mentioned it with the HSG, but basically we want to see inside the uterus. When we do that normal ultrasound to look at the ovaries, we're really only seeing the uterus kind of in cross section with the walls closed. So something like a saline ultrasound or sonohystogram or SHG, again, love the acronyms around here. We're going to actually open the walls with this black water, and you can see the very top picture looks like a perfect uterine cavity. It looks like very nice. The walls have opened. Whereas the one below it, you see this big white thing coming out. So definitely this little one probably is a polyp, which is a benign overgrowth. The bottom one might be a very large polyp versus a potential fibroid. But definitely that would be something we need to fix. We could do a minor surgery called hysteroscopy, which is kind of like a colonoscopy of the uterus, where we're actually going to go in with a camera and be able to take out what's in that uterus to fix it, so that that is a nice place for an embryo to hopefully implant. Definitely in terms of things like we said, polyps, which are just benign overgrowths, fibroids or smooth muscle overgrowth. They can be inside the cavity like we see in this top, kind of that middle picture, or they can start growing into the walls of the uterus. And so depending on kind of where your fibroid is, how big is it, what symptoms you have, you may or may not need a surgery. Definitely if you've had previous surgeries to your uterus, there could be scarring within the lining. And so that would be something that we need to fix. And then sometimes people actually have kind of technically a birth defect. It's called a Müllerian anomaly, something like a septum, where instead of having your cavity like this, there's actually a little wall in the middle. And that happens when the embryo, when you were an embryo, is basically growing. And typically kind of the left and the right parts of the reproductive tract come together. And then this middle part is supposed to kind of degenerate and come to become this uterus like this. So if that doesn't happen, it stays there as a septum and it makes it harder to get pregnant and it increases the risk of miscarriage. So that's something we could correct with a hysteroscopy surgery. So again, finding all about the uterus is really important. And then from that, kind of getting a nice lining and then hopefully the rest of the cavity so that you can hopefully have good chances of pregnancy. So kind of said this, but the top part is that hysteroscopy, meaning kind of looking in with the camera. And you can see this was a polyp and we've already started to kind of resect part of it. Below it is the actual procedure itself, which is called hysteroscopy. Definitely if you have really large fibroids, sometimes we need a more extensive surgery called a myomectomy, where you might either have that done robotically or potentially as an open, typically using kind of an area that you would have the C-section incision, if that was a really big or many large fibroids in the muscle part of the uterus. Or in the case, unfortunately, that there's major problems with the uterus, sometimes someone would actually consider a surrogate, which kind of the technical term is a gestational carrier. But again, just figuring out what's going on with the uterus is important for implanting an embryo, but also having a sustained pregnancy. So then we come to the sperm. And so if you have a partner, definitely we would want to check the sperm. So we do that with a semen analysis. With that semen analysis, we look at a bunch of different things. We're going to look at how much fluid, which is called volume. We're going to look at the number of sperm. We're looking at how they're moving, which is called motility. We're looking at the shape, which is called morphology. Depending on all that, definitely if everything was low or there's major issues, we might actually refer him to a urologist, which is a male reproductive tract specialist. If certain things are minor, there's things that we might be able to recommend in terms of lifestyle changes. Or if someone has no sperm source, definitely we'd have you order donor sperm, which has already been screened for all of it. So in terms of treating this male factor, definitely sometimes things that are somewhat easier can actually help a little bit with some of the sperm parameters. So just a fertility supplement, something you just buy over the counter, things with zinc, lycopene. They're just all called kind of male multivitamins for fertility. That could help a little bit with certain parameters. Lifestyle changes. So if a man is continually exposing kind of his reproductive tract to hotter temperatures, so a lot of saunas, hot baths, keeping your laptop in your lap all the time, those are all things to try to decrease, to potentially improve things like a little bit on the motility or morphology side. Kind of getting rid of toxic habits, so definitely marijuana use, smoking, getting rid of those, we can definitely see an increase. And then just making sure to be a good body weight, kind of exercising enough, but not too aggressively, and definitely not taking something like testosterone. But based on what we see from the semen analysis, if everything's just a little bit low, something like an insemination or IUI could be helpful. Versus if it's very severely low, at that point we would need to move to IVF with what's called ICSI, or intracytoplasmic sperm injection, where we're actually going to pick the best sperm to put into the egg, which is what you can see in this picture. And so those would all be things that we would talk about at a consult after going through all of your history, his history, and then getting all the results back to kind of figure out what the best course of action would be. So at this consult, which like we said, by attending tonight, you get a free consult with me. So I'm excited to do that. And basically with that, we would go through a full evaluation of your history. So all about your GYN history, your periods, have you ever had a sexually transmitted disease, medical problems, surgeries, any exposures, family history. If you have any medical records, I always love to look at those before our consult. And if you have a partner, his history and potential records as well. With that, we would then be able to do some blood work. So routine lab work that's helpful for the female would be things like your thyroid and prolactin. Those are hormones that could potentially impact the fertility hormones we talked about. Your blood count, what's your blood type? We do what we call preconception labs to make sure that you're in kind of the perfect health condition to hopefully get pregnant. So are you still immune to chickenpox, rubella? We just do an STD or STI screening. Genetic carrier screening you see on here. This is a test that looks for about 300 different conditions. Most of these are what we call recessive, something like cystic fibrosis or sickle cell anemia. These are major diseases that could affect a baby. It really would only happen though if both the egg and the sperm were a carrier, and then combining that, there's a 25% chance a baby has it. So as a carrier, you have no idea sometimes that you have it, but if both you and the sperm are carriers, then definitely we would want to know that, because we would potentially be able to do IVF where we check embryos for that condition. And then we just want to make sure you're up to date on things like your pap smear, your mammogram, and then if you have a partner, he would also do STD and the genetic carrier screen. And then in addition to all of that, like we discussed, all of the fertility workup we already went through. And so at that point, we get all this information, kind of figure out what we see. It's like we said, IUI is definitely a reasonable option, especially if you're younger. If you really have everything looks good on the testing, the sperm looks good on the testing. And typically when we do an IUI or intrauterine insemination, we typically will combine that with a little bit of a fertility pill for you. And so that fertility pill, it's either called Clomid or Letrozole. And the thought being is that if you do get regular cycles and you have been trying multiple months, unfortunately, you're just not getting pregnant. And so is there something wrong with the eggs, or is the egg quality a little bit less than we might expect? So the thought is let's give you this fertility pill to try to increase the number of eggs coming out in a month. So typically you would just have your one. So depending on the age, we might be aiming for 2, 3, 4, 5, depending on age. Definitely because we're getting more eggs, your chance of having twins would increase, but really that would be a specific kind of evaluation based on your age and numbers. And typically we'd still keep that chance of twins definitely in this usually low single digits, just because unfortunately as we get older, the chance of having abnormal eggs increases. And so if you're in your higher 30s, the thought is that even if we get you 3 or 4 follicles, maybe it's only one good egg. And so that's why your chance of twins is still low. And so we do that. We monitor you, meaning that you would come in usually for 1 or 2 ultrasounds after you take your pills. And at that point, when the follicle, which is where the egg is nice and big and ready, you would take a special trigger shot, meaning that we're actually going to help you ovulate at a certain time and then time your IUI out from that. And so we're making sure that you have hopefully more than one egg, you ovulate at the right time, and then the IUI itself is going to be preparing the sperm, getting all the best, fastest moving sperm, and then actually putting a nice chance. A couple caveats to that, definitely if you do not ovulate, so you have something like polycystic ovary syndrome, we would still give you the medication, but at much lower doses, because we're really just trying to get your one egg a month to come out, because you typically don't have any. And so that'd be the one kind of change. And then in terms of kind of what are success rates of IUIs, that again relates directly back to your diagnosis, your history, your age. Really the thought is that if you were doing this for something like PCOS, where we're just trying to get you to ovulate, or maybe there's very minor things with the sperm, maybe we could bring your chances back up to about that 20% that we talked about in the beginning in terms of just natural conception. But if we're doing this for what we call unexplained infertility, meaning that we've done all of the testing we talked about, everything came back looking good, unexplained infertility basically means that there is something going on. We don't know what it is because the tests look normal. For unexplained infertility, really, we think there are couples that would be able to get pregnant with a medication IUI cycle. And then unfortunately, there's the other group that probably won't ever be able to. Maybe the outside of the egg is too hard to penetrate naturally, things like that. And so because of that, overall, for all unexplained infertility couples, the chance of getting pregnant naturally kind of drops down to the single digits. And so something like a Clomid IUI cycle is going to bring that back up to about 15%. So yes, I did say only 1/5. And so that's something that's really important to understand, is that while we are increasing your chances, it's still low. And so we would go into a medicated IUI cycle, understanding that probably we'd have to do this a few times. If we're not pregnant after the 3rd cycle, really the data shows that the numbers start to go down from the 15%. And we would think you fall into that other subgroup of a couple that's not being helped out by a medicated IUI. So all things to think about when we're trying to figure out IUI versus our next one, which is IVF. So in terms of IVF, definitely, like we said, if we've done multiple IUIs, we'd move on to IVF. Reasons we would not do an IUI at all and go straight to IVF would be if you had blocked fallopian tubes. Sometimes major endometriosis is affecting everything, so we would just go straight to IVF. Unexplained infertility, like we said, definitely depending on your age and numbers, sometimes we might start with an IUI. Sometimes if someone is older, usually over 38, we may go directly to IVF. Or sometimes after hearing kind of both processes and the success rate, sometimes people want to go directly to IVF for a much higher success rate, in addition to the ability to check chromosomes of the embryos and actually keep extra embryos frozen, so that besides just getting pregnant now, you're actually getting extra embryos maybe for the future, depending on all your testing. Some other reasons people might go straight to IVF, definitely if there's a major sperm problem. If someone has had multiple miscarriages, often miscarriages are happening from abnormal chromosomes. And so sometimes people want to go directly to IVF so we can check the chromosomes of the embryos before we put them back in. Kind of along with that, sometimes people want to do gender selection, meaning they want to pick a boy or girl. That's type of chromosome. So we get that along with making sure it's not Down syndrome, other types of chromosome problems. Or that carrier screen we talked about, where we're looking for things like cystic fibrosis, sickle cell anemia. If a couple are both carriers of the same thing, we would recommend going straight to IVF so we can actually check the embryos for that. Because really that test with about 300 different conditions, all of those conditions are either lethal or very highly kind of major impact on a baby or a young child. And so oftentimes we would want to make sure to pick an embryo that would not have the full disease. And then kind of other reasons to go straight to IVF would be kind of previous sterilization. So from a female side, if you've had your tubes tied, it's very hard to reverse them and typically not successful. We go straight to IVF. Same thing for a male. In terms of trying to reverse a vasectomy, it really depends on, did you have it done a long time ago or more recently? But often we might go straight to IVF. So in terms of what is IVF, definitely you probably heard about it. A lot of times, obviously, people feel a little daunted by the IVF process. But kind of briefly, it's about a 2-week process where we would stimulate your follicles, which are where the eggs are, with injections. The thought is that typically you're normally getting the FSH, or follicle stimulating hormone, that comes from your brain, talks to your ovary, and you get your one egg that grows in the month. And all of the rest of the eggs in the ovary that month actually go away. They degenerate. So the point of IVF is you take injections of higher doses of FSH to get a lot of your eggs in your ovary that month to grow. And then we actually will take them out with our egg retrieval process. And so how do we do that? You do these injections for about 2 weeks. During that time, you come in every couple of days for what we call monitoring, which is ultrasounds and blood work. Kind of this top picture is a nice picture showing lots of follicles growing. So instead of just that one follicle that we talked about before naturally, now hopefully a lot of follicles are growing. And when those are nice and big and ready, you take the special trigger shot to get the eggs ready to come out. About 35 to 36 hours later, we would do the egg retrieval procedure. We do it with a transvaginal ultrasound as well, with a very kind of small needle that goes through the vaginal wall into the ovary, and it takes the fluid out of each of those little black circles called follicles, and within each one of those is the microscopic egg. And then the rest kind of happens in the lab. And so with that, the embryologist will pick all of the what we call mature eggs. Those will get combined with the best looking sperm with the process we talked about before called ICSI, or ICSI, or intracytoplasmic sperm injection, where the best sperm is put into each one. And then we will culture out the embryos and do the transfer. But I have some slides going through this in a little bit more detail. So in terms of pre-implantation genetic testing, so like we said, these embryos are going to grow. And so in this picture, you can see the first day 1 embryo is just the egg and sperm that came together correctly, which is called a normally fertilized embryo. And you can see throughout the days, it's going to multiply and divide until we get to the 5th or sometimes 6th day, where we have over 100 cells. There's going to be a ball kind of in the corner, which is called the ICM, or inner cell mass. That's going to become an actual baby. And the part around it is called the trophectoderm, and that's what's becoming the placenta. And it's from that area that we take a couple of cells where we can actually do the chromosome testing. And so with that, we're checking all the chromosomes, which, like we said, would include gender if you're interested, or we could keep it blinded. And from that, we're able to pick all the best normal chromosome embryos for you, so we can put one back and have very high success rates. And so nowadays, because we do chromosome testing pretty much on all cycles, because it's just such a great tool, we really nowadays only do single embryo transfers. And the reason for that is that with one normal chromosome embryo, the chance of getting pregnant after implantation is about 75%. So it is massively increasing the chances of pregnancy because we know it's normal chromosomes. It's also kind of changing what the kind of impact of an embryo is based on someone's age. So in the past, before the chromosome testing, over 35, we'd usually put back 2 embryos with a thought only 1 is normal. Over 40, we might even put back 3. But because we know it's normal chromosomes, it kind of standardizes and kind of takes away the impact of age. And we know that that 1 normal chromosome embryo has such a high chance, we would just put the 1 back because you'll hopefully be pregnant. And so a lot of times people ask, well, why do we always hear about IVF causing twins, more than twins? And really that was in the past. Now that we do chromosome testing, which is called pre-implantation genetic testing, or PGT, or is previously known as PGS, really we only do single embryo transfers, except for rare cases. Just to talk about something that's kind of in between IUI and IVF that a lot of people probably haven't heard of yet. It's called InvaCell, or intravaginal culture, and it kind of combines the two. So the whole point of IVC is you would still do kind of similar to IVF, where you're going to take injections to hopefully get lots of eggs to grow, but usually at lower doses and with less times that you need to come in for monitoring. At the end of it, you still have the egg retrieval to take those eggs out. And this is where it's different. So at that point, we take the eggs out, we have the sperm, we actually put them into this little device, and that device actually goes into your vagina. So you actually serve as your own incubator for 5 days. And then at the end of that, you come on back. We would be able to take that out, look for embryos within that, and then from that, pick the best looking embryo to put in as a transfer that same day. The rest would get frozen. Because this is really trying to decrease kind of utilizing the lab, decreasing obviously major costs to you, it's really only for specific people. So if you're younger but you have a Tubal factor, this definitely could be a good option. If you, for example, are a lesbian couple and one person would like to get her egg stimulated and the other wants to do the IVC, so everyone's kind of part of the process, that's absolutely fantastic and a good way to use IVC and hopefully get lots of extra embryos. People this wouldn't be for would definitely be someone with major sperm problems, because we're not overcoming that with this. Someone with unexplained infertility, again, we're not overcoming fertilization or anything like that. Someone who's older with lower numbers, this again wouldn't be the way to go. And then because this is a much easier, kind of less involved with the lab, we don't do the chromosome testing. So definitely that would be something to be aware of. And so the chances with this are about 50-ish% with an embryo that's put back for the younger, well-selected patients. Overall rates, if we included everyone, is more like 25%. So something to think about though, depending, and that would be something we could talk about in a consult. Just to talk a little bit about IVF with donated eggs. So sometimes, unfortunately, based on age or other factors, it wouldn't be possible to use your own eggs. And so that would be a reason that we could consider doing an egg donor. So whether that's specifically getting an egg donor, typically we do this anonymously, and having her cycle, and when those eggs are taken out, they get combined with the sperm, and at that point they're considered your embryos. You still go through the process, we put the embryo back, you get pregnant, you carry the pregnancy. Because donors are typically in their low to mid 20s, very high pregnancy rates, which is great. You have a lot of say in picking that donor. You can put in kind of whatever requests you want. Definitely kind of the more specific they are, maybe the little harder it is to find a donor, but definitely a good option for someone that has very poor kind of egg reserve or quality, potentially already in menopause. So all things to consider. Kind of beyond donated eggs, there's also the option of donor embryo. So that would be something too, where there's embryos that have already been created that potentially you could actually use. And that, again, is usually anonymous as well. Sometimes people might have a major problem with the uterus. Either they've had multiple miscarriages, or they can't get pregnant, or we already just know there's a major issue with the uterus, or potential other medical conditions that would keep you from wanting to carry a pregnancy. That's when we would help you find a gestational carrier, or kind of more slang term would be surrogacy. And so that would be finding somebody else to carry the embryo for you. And so she goes through a lot of screening, make sure she's a good candidate. But basically she would carry the pregnancy, and then at the end, when the baby's born, obviously that would be going home with you. Third-party reproduction. So definitely gay couples, we can help you find an egg donor and a surrogate. Lesbian couples, definitely more options. So we could just use the donor sperm with an IUI. Sometimes we would still use fertility pills. Sometimes we might just do a natural cycle. The IVC, like we said, the InvaCell, that would definitely be a good option. Or we could do IVF, where we're going to create all these embryos, and potentially either partner could carry that pregnancy. Fertility preservation is something to also talk about, just briefly here, but if you're interested specifically in this, I'm actually next week on Thursday going to be doing a webinar all about egg freezing. So definitely you can tune in then for more specifics. But in terms of just fertility preservation, definitely, in the past it was done kind of for urgent issues. So egg or embryo freezing for cancer or other types of treatments similar to that. For example, someone with lupus about to get a chemotherapy drug for that. Sperm freezing, so cancer patients, testicular cancer, things like that. Sometimes men pre-vasectomy would do it just to kind of keep a sample in the freezer. And then definitely if you undergo any type of surgery down there, for a male, freezing a sample is always good. Nowadays, the elective kind of egg freezing and also sperm freezing has become a lot more popular. In terms of egg freezing, definitely the thought is we're kind of freezing your fertility at your current age, which is really helpful so that in the future, whenever you are ready to get pregnant, you essentially are your own egg donor. So you have these eggs in the freezer. Nowadays, we have great technology. They have really high thaw rates. About 90% of the eggs will thaw. And then at that point, they're considered equivalent to a fresh egg. So definitely something to consider if you're not trying to get pregnant. Absolutely, like we had said in the very beginning, just coming for a fertility consult just to get your information is always nice. And then from that, making a kind of plan. Do you want to do egg freezing to have them? Potentially, did you do this fertility workup and actually see that the egg numbers are a little bit less than we might expect for age? That would definitely be a reason to consider egg freezing. But really, egg freezing is everything we talked about kind of for the IVF process. In terms of the injections and the monitoring and the egg retrieval. And at that point, we basically kind of stop the cycle, the eggs get frozen, and then that rest of the part of creating the embryos and doing chromosome testing and everything, that would happen in the future whenever we pick sperm to then combine with the eggs after we thaw them. So that's kind of the end about fertility, is talking a little bit about HRC. HRC has been around for a long time, which is fantastic because we have such a great reputation and we've been around for so long. We have long proven success rates, which is really important when you're picking a fertility office. We're throughout Southern California. Like I said, I'm in the Orange County office, but we also have the Encino and Pasadena locations. And then within each of those three areas, we have multiple office locations. We have multiple REIs, which is what we are, reproductive endocrinology and infertility doctors or fertility specialists, I guess for slang, that are dedicated to excellence. And like we said, we have very high pregnancy rates. We are the largest fertility practice kind of west of Chicago. Sometimes people say, well, I want to go to a small fertility practice, but really a large one is what you're looking for. And the reason for that is that our lab is continually going through quality assurance because we have high numbers of embryos. And so within a day, if numbers are looking to be a little bit lower, things are fixed or changed out. Whereas if you had a very small office with a very low volume lab, that could take a month or so to really realize that maybe one of the incubators is not functioning quite as well, or there's an air quality issue or things like that. So we have fultastic reputation, specifically for the HRC Orange County, San Diego offices. We've been around since 1998. We're in Newport Beach, Laguna Hills, Fullerton, and Oceanside. Very, very high pregnancy rates. So definitely a reason to come to us. A little bit more about myself. So I am double board certified, meaning I'm OBGYN and REI subspecialty certified. I've been doing REI things for the last 11 years. I've been in specific practice after residency and then fellowship for 4 years. Prior to this, I was an attending physician and assistant professor at Columbia University Fertility Center in New York City. While I was there, I was actually the director of egg freezing and oncofertility. I worked a lot with Sloan Kettering, also did a lot, obviously, with the infertility as well. And so really, I love the area. I love talking about fertility, fertility preservation, infertility, IVF. I've made multiple appearances on things like the Today Show twice, for example, and other types of media sources. So I just love what I do. I love connecting to patients. And so I would love to meet with you as a consult. Like we said, by joining us today, you're entitled to a free consult. So definitely feel free to reach out. You can go through our website to book that appointment. You can call us. Just briefly about the coronavirus, we are doing our part to flatten the curve. And so at this point, we are doing all consults virtually, whether by phone or Skype. But we are still doing them, so you could absolutely make an appointment, even potentially for later this week, definitely next week. And with that, we could at least get a plan going so that when everything is better, hopefully somewhat soon, we could absolutely move forward with a treatment if that was what you're interested in. So at this point, I'm just going to open it up to questions. While we were talking, it looks like we've had a couple questions come up, but still, you can keep typing in your questions. Like we said, if it's a very specific personal question, absolutely, I can answer that in a consult. But in terms of kind of the specifics, kind of the general specifics, I can go through that right now. So we had a couple questions that kind of as we went through, it looks like we answered, but someone asked a little bit about kind of the timing. So in terms of timing, typically you'd come in for a consult. At that consult, you'd meet myself, my coordinator, and a finance person. And from that, we can kind of move as quickly as you'd like versus as slowly as you would like. but typically it takes about a month sometimes to do all of the testing, just because a lot of it is specific to your period. So like we said, when we check your ovaries, the ovarian reserve testing, that is done on the second or third day of your period with the ultrasound and the specific blood work. And then if we're going to do that radiology test to check the fallopian tubes or HSG, that's done after you stop bleeding, but before ovulation. So really kind of those two things are time dependent. All of the general blood tests can be done whenever, and a semen analysis can be done whenever. But typically that all takes about a month or so to kind of get everything done. And then at that point, we could figure out moving forward. If someone has insurance coverage, which hopefully you do, sometimes it actually does make it a little bit longer, because once we get all that information, it goes into what we call pre-authorization. Sometimes insurances require, and then you need to wait for them to approve it to move forward with the cycle. But if you unfortunately don't have insurance, kind of one silver lining is you can move forward typically with that next period, just because you're not waiting for pre-authorization. Otherwise, sometimes it could be a whole month potentially waiting, or other times if it looks like it's a quick pre-authorization process, usually with a period, you could go on a little tiny bit of birth control to kind of keep you ready to start. And maybe about a week into that or so, you could go into the process. So there is a question about cost. And so that would be something you could definitely talk about with our financial advisor after your consult. Like we said, definitely there's some insurances that cover it. Fortunately, some do not. There are different ways to finance IVF cycles, and so those would all be ways, things that you can talk about with a financial advisor. Things like IUI cycles, there are some insurance companies that might require those before moving to IVF, but again, all dependent on your insurance, and kind of that would be something absolutely your financial advisor would go through. Let's see, so we have a question about egg donation. And so in terms of egg donation, we would be able to help you find different agencies. So there's a lot of different agencies out there if someone is looking for an egg donor. There's two different ways of doing egg donation. There's anonymous, which is what we typically would do, meaning we would help you through an agency find a donor. You would never know her name or meet her. She would never be able to come, meet the baby or anything like that. It's totally closed and anonymous. But basically the agency would help set that up. You'd have all your parameters you're looking for, and they'd help find that. Sometimes then when she would go through the cycle, financially, if sometimes you would actually split her eggs with another couple sometimes, versus take all of the eggs to make many embryos to hopefully be used for multiple, future pregnancies as well. Another option kind of within the anonymous would be sometimes already frozen eggs. So that's a good option as well. Really the thought is that they're almost equivalent to doing a full fresh cycle. You do get a little bit less in terms of number, just because typically you're only kind of buying a certain number to try to get one embryo. So if you're thinking of trying to create embryos for multiple pregnancies, sometimes people like to just go the fresh route. But those would all be things we could talk about, and an agency would help you with. Kind of the other much lessly used way to do egg donation would be a known donor. Definitely there's a lot of things that go into that, like legal, psychosocial, but that would be a secondary option. There's a question about kind of what happens to embryos that we don't use. So that's a great question. So definitely along the way of this whole process in our lab, there's eggs that don't fertilize. There are embryos that stop growing along the way. And then when we do the chromosome testing, there's definitely ones that are going to come back as abnormal. So typically all the abnormals, unfertilized, things like that, we would discard. And then any of the good normal embryos, those stay frozen. So hopefully you get pregnant. We said 75% chance of implantation. If you still have extra ones, they stay frozen. And then hopefully your second pregnancy, third, however many babies you want, you keep using those embryos. But obviously, if you have many of them, you might not want to use all of them. And so at that point, you'll see when you go through the IVF consent forms before even doing the cycle, you would consent to different options. So one option would be discarding, where they would just be discarded. The second would be donating to research, where the embryos would not be grown out any further and they'd be used for kind of life-changing research. Or the third would be actually donating that embryo anonymously. And that's kind of what we talked about before, where you could adopt an embryo. So all good options. Let's see, I know we're going a little long at this point. I think we might have answered all the questions. I'm just quickly scrolling through. So it looks like we've answered all the questions. So at this point, definitely feel free to reach out if you come up with other questions, but definitely, like we said, I'd love to meet you. Like we said, right now it might be virtual, but hopefully in person very soon. And at that consult, we can go through all of your specific information. And so for more information, you can absolutely, like we said, go to the HRC website, havingbabies.com. You can go on our Facebook pages or Instagram pages for some more information. Kind of throughout all of this coronavirus, we are doing Facebook Lives with little tidbits of information. So definitely feel free to follow us on Facebook and Instagram. But I look forward to hopefully meeting you soon. Thanks for watching. Have a great night. Stay safe and healthy.